Before we get started, just a reminder that please let us know that you have attended this lecture by answering a brief survey that will be sent to you by medicine reception at the end of the presentation. And please leave your questions till the end, enter your questions in the chat, and we will go through them all at the end of the presentation. I would like to introduce our speaker today, who's coming to us from the Division of Allergy and Immunology here at McGill. Dr. Geneviève is already known to many of you. She received her medical degree from the University of Montreal. She did residency training at Université Laval and her subspecialty training in immunology and allergy and immunology here at McGill. She went on to complete a reproductive immunology fellowship at the University of Toronto and has been back at the MUHC since 2017. She has created the first Canadian university-based reproductive immunology clinic and fellowship program. And she's currently a PhD candidate at McGill under Bruce Mazer and Chio Piccirillo. And it is a great pleasure to welcome you, Dr. Geneviève Genest, to give us our medical grand rounds today. Welcome.
And thank you so much for this opportunity. I'm going to share my screen. I'm sorry for the messy desktop. Hopefully I'll be able to have my presentation uploaded without any issues. And here we go. So yeah, again, thank you so much, Dr. Genetti, for giving me the opportunity to present at Grand Rounds. I will be talking about COVID vaccination and pregnancy, and I entitled my presentation the way I did more to increase the attendance at Grand Rounds and not because I wanted to advance some kind of anti-vax agenda. So for those of you that have been texting me and emailing me with questions, you don't have to worry. And I thought that this was, a very important thing to discuss as a medical community, because I think some of our vulnerable populations are not being adequately counseled in terms of COVID vaccination. So I really want to increase the vaccine uptake in that patient population. And unfortunately, at this stage of my career, I don't have any disclosures. And in terms of educational objectives, at the end of this presentation, I want you to be convinced yourself that you should be vaccinating pregnant women. And I want you to be able to convince your pregnant patients to get vaccinated. So the problem that we're facing with social media and with fake news is that patients all have different arguments as to why they should or should not be vaccinated. And I want us to be able to face those questions and face those concerns head on with appropriate scientific evidence so that we can appropriately guide our patients. Now, I thought it was very important to present this topic because in the last 20 months at the MUHC, in the ICU and in the COVID wards, we've been caring for an increasing number of pregnant women that have COVID. And a lot of these pregnant women are quite sick with their COVID. And one of these cases recently made the news and required an incredible collaborative effort from the obstetric medicine team, maternal fetal medicine, intensive care unit, and OBGYN to save the life of a critically ill mother and her unborn child, Bella. And, what you've probably most heard about this because it made the mainstream media and it was talked a lot about within the MUHC. But what most of you don't know about this particular case is the crucial participation that the immunology service had in this very miraculous save. So if most of you are wondering why, well, the key person is this person right here. This dashing young doctor is named Dr. Mark Beltempo, and he's a neonatologist at the Children's. He also happens to be my husband. And on the day of this very cool case, Dr. Beltempo was not supposed to be working. He was supposed to be working from home, but I kicked him out of the house because I wanted to be able to work uninterrupted. And I also wanted no competition for the coffee machine. So Dr. Beltempo took our youngest daughter to daycare, went to work at 7:30 and witnessed his colleague falling violently ill to gastroenteritis on that same morning. So he offered to take on the service that day and replace him on the ward. And he ended up coordinating the NICU portion of this pretty cool collaborative save. Now, anecdotes aside, again, we've been seeing more and more severe and critical COVID, especially in the late second trimester and in the third trimester. And although there's a low risk of neonatal and infant transmission of COVID, probably because neonates don't express the same level of ACE2 receptors as we do, or that maternal behavior in terms of wearing face masks and washing their hands, there's a lower transmission rate from COVID positive mothers to their infants. But still, if you take an infant and a young neonate, so less than, or a neonate, sorry, and a young infant, so less than 6 months old, if they do catch COVID, they have a higher risk of being hospitalized and being hospitalized in the intensive care unit than children that are older than 6 months old. And then the other thing that we have to keep in mind as internists is the importance of the maternal condition on neonatal outcomes. So if you have a mother who's acutely ill with COVID, she's probably hypoxic, she's probably hypotensive, she's probably quite inflammatory. None of these things are particularly good for the placenta, and none of these things are particularly good at keeping the baby in an optimal condition. So again, a sick mother means a sick neonate as well. So we really do have to keep that in mind as internists. Now, about a year and a half ago, most early reports that were coming out of Italy, China, the US reported that pregnant women did not have an increased risk of severe COVID compared to non-pregnant adults. However, this changed in 2020 when the CDC emitted a special report, and this kind of changed that paradigm. So this CDC bulletin was published in June 26, 2020, and basically they were able to collect data from over 300,000 COVID positive women of reproductive age, so between 15 and 44 years old. And of those patients, actually, sorry, if you guys don't mind, I'm just going to take my picture off because my internet connection is unstable and I might lose you all. So I'm just going to stop my video and continue the presentation. All right, so they were able to collect data from over 300,000 patients that were of reproductive age and that had COVID. And for those 300,000 patients, they had status about the pregnancy in 91,412. And of those 90,000 people, 8,207 patients had COVID and were pregnant compared to 83,205. So they were able to compare COVID positive pregnant mothers with age-matched COVID positive non-pregnant women. And keep in mind that this was pre-Delta variant and pre-vaccination. And in terms of groups, so the pregnant women and the non-pregnant women who all had COVID were relatively well matched in terms of age, race, ethnicity, and symptomatic status. There were a little bit more chronic medical conditions in the pregnancy group, and that's probably because in the US, if you're pregnant, this is usually your first contact with the medical system, or if you have a chronic medical condition and you do become pregnant, you're more likely to be closely followed. So chronic medical conditions can be overrepresented in the pregnant group, but by and large, groups are relatively similar. And basically what they were able to do is they were able to look at the outcomes of pregnant women and non-pregnant women and stratify according to age. So if you were pregnant and had COVID, your chances of being hospitalized was 3 to 10 times greater than if you were not pregnant, depending upon your age group. The same trend goes for ICU admission. So depending upon your age group, you are 2 to 3 times more likely to be admitted to the intensive care unit if you were pregnant and had COVID versus if you were COVID positive and not pregnant. And then same trend for mechanical ventilation. So again, 2 to 3 times more likely to be put on mechanical ventilation if you were pregnant and COVID positive versus if you were only COVID positive. Now, thankfully, the death rates were similar in both cohorts, but still, this preliminary report does show that there's a clear maternal morbidity associated with COVID in pregnancy. Now, some of you might say, but how can you possibly distinguish hospitalizations due to COVID versus those that were related to obstetrical complications. And then, someone else may say, well, you didn't have any appropriate controls. And this is absolutely true. And these issues have been addressed in several different publications that are slowly making their way into the literature. And all of these publications are showing that pregnant COVID positive mothers have worse outcomes than COVID negative pregnancies or COVID positive non-pregnant age-matched women. So I'm only presenting one article as an example. And the reason that I'm presenting this study is that it's a Canadian study coming out of New Brunswick, so our colleagues in the Maritimes. And basically in this study, they were able to identify consecutive pregnant patients who tested COVID positive, and they were basically identified prospectively in a clinical database. And the patients that were included were from March 2020 to June 2020. So this coincided with the first 3 months of the lockdown in New Brunswick. And these pregnant COVID positive patients were matched 1 to 2 with pregnant COVID negative controls by delivery date. Now, the COVID cases were categorized as mild, severe, or critical based upon the usual definitions that we all use in clinic. And they were able also to measure maternal outcomes. So we're talking about preeclampsia, venous thromboembolism, admission to the hospital, ICU admission, and mechanical ventilation. And they were also able to look at certain neonatal outcomes, such as respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and an APGAR of less than 5 at 5 minutes post-birth. So in this small study, there were 61 COVID cases that were identified. And so these are 61 COVID positive pregnant women compared to 122 COVID negative pregnant women that were matched to gestational age. In terms of groups, they were relatively comparable, maybe a little bit more white and a little heavier in the pregnancy group, but also a little more medically comorbid in the non-pregnant controls. But by and large, these two groups were relatively comparable. And what we can see in the patients that got COVID is that by and large, most of them are mild. They have mild cases of COVID. So the patients usually were identified if they were symptomatic. So you do have to keep in mind that there is a bias towards symptomatic patients. So of those symptomatic patients that were pregnant, most of them had a mild disease. However, 10% of these patients also had severe and critical disease, which is way more than what would be age expected, which we're going to see in the next slide. And then they went on in this article to detail that the patients that had more severe or critical disease had higher rates of medical comorbidities like diabetes, chronic hypertension, renal disease, and anemia, and they were more likely to be Black or Hispanic. So this also reflects what is known in the general population with COVID. So again, from this publication, it's quite apparent that pregnant women are at increased risk of severe COVID. So, 10% of the women in this cohort had severe or critical disease. And if you look at the latest CDC estimates for hospitalization in this age bracket, so 18 to 40 years old, you have a risk of hospitalization of 0.025 to 0.05%. So this is all COVID, all COVID positive patients. If you are symptomatic, probably that your risk of being hospitalized is a little bit more, but nowhere near the 10% that we're seeing in pregnant COVID positive mothers. Now, if you look at the outcomes of these pregnancies and the neonatal outcomes, the patients with severe or critical disease obviously fare much worse than patients with COVID that have mild disease or than COVID negative controls. So the patients with severe or critical disease are obviously more likely to be admitted to hospital, more likely to have a cesarean section, more likely to deliver preterm, more likely to have preeclampsia, to have non-reassuring fetal tracing on the ultrasound before delivery. They deliver at lower birth weights. This is probably related to the fact that they deliver preterm as well. well. And then their babies also have worse outcomes. So obviously 100% of these babies are admitted to the NICU. They stay a lot longer. They have a higher risk of respiratory distress syndrome and a higher risk of intraventricular hemorrhage. So again, these are probably related to the prematurity of the neonates, but it could also be related to placental dysfunction. I mean, having very severe inflammatory reaction to COVID probably causes a certain level of placental dysfunction. So is it placental dysfunction or is it prematurity? At this stage, we're not entirely sure, but we can say, with a certain level of confidence that patients with severe or critical COVID have much worse maternal outcomes, but also fetal outcomes as well. So again, it seems that pregnancy increases your chances of developing more severe COVID, with 10% of symptomatic patients having severe or critical COVID. But why is this? How can we explain this disease propensity physiologically? Now, as we all know, and this is something that we've been learning over the last 2 years, the SARS-CoV-2 virus is transmitted by respiratory droplets and aerosols. It enters the body via the nasal passages, and it infects the pulmonary cells via the SARS-CoV-2 receptor, which is the angiotensin receptor, the ACE2 receptor. The virus will bind to the ACE2 receptor via the spike protein, requires the transmembrane serine protease to be primed for viral entry. And once that occurs, the virus hijacks the cell's mechanism to produce more virus. And eventually, the virus has to be released from the cell to be able to infect more cells. But this release of the virus causes something called pyroptosis, which is inflammation-mediated programmed cell death of the host cell. So the virus not only infects cells, but it also causes those cells to die once the virus has used that cell to replicate. So it can cause lung damage. Now, this pyroptosis, or inflammation-mediated programmed cell death, also releases something called damage-associated molecular patterns, or DAMPs, that trigger an inflammatory response from neighboring cells. And there are basically two types of immune responses that dictate the clinical course of a COVID infection. And so the first case on the left, this is the case where you really have an excessive production of pro-inflammatory cytokines. And this basically attracts immune cells such as monocytes, macrophages, and T cells to the infection site, and causes this positive feedback loop that leads to excessive inflammation and will damage the integrity of the lung. And this can result in infection with other microbes, like host microbes, for example. And then the inflammation caused by this positive feedback loop also can result in something called a cytokine storm that basically leads to multi-system organ failure. And it's thought that this excessive inflammation is the cause of severe COVID, and this is associated with high mortality and high morbidity. However, there's another way in which the immune response can react to the COVID virus, and this is a more normal way to react. And this, is probably what happens in patients with mild symptoms. So it's likely in this case that the immune system reacts appropriately. So without having a preformed adaptive immune response, the immune cells can clear certain infected cells before they spread further and further replication of the virus occurs. The virus, for example, can be blocked by neutralizing antibodies and tag other virally infected cells or viral particles for clearance by phagocytes. Non-specific T cells can also, do something similar. So this limits the spread of the virus and of the inflammation-induced lung damage, and this results in mild or asymptomatic disease. So again, very different pathophysiology between patients with severe COVID versus those that are either asymptomatic or have mild disease. Now, how can pregnancy affect that immune response? So what you have to know is that the immune system during pregnancy undergoes very impressive changes to accommodate a fine balance between tolerating the semi-allogenic fetus and maintaining maternal immune competency, and probably that the response to COVID is affected by these changes. So for example, the first trimester is characterized by local inflammation. So inflammation only occurring at the site of implantation in the uterus. And this basically accommodates the implanting embryo and will kickstart early pregnancy. And eventually, these events will trigger maternal immune adaptations to tolerate increasing exposure to the antigenically dissimilar fetus in the second and third trimesters. So the first trimester is not necessarily associated with increased risk of maternal morbidity if that patient catches COVID. However, during the second trimester, we really have this skewing towards immune tolerance, again, to tolerate the antigenically dissimilar fetus. And this has systemic ramifications. So most of the time, a woman in her second trimester retains immune competence, but she can be more vulnerable to certain infections. And we think that because of the reduced inflammatory response, women in the second trimester may have decreased responsiveness to certain viruses, and this is associated with a higher viral load and a higher risk of maternal and fetal complications from certain respiratory viruses, just because the viral load is so high, and this basically damages the cells that the virus is infecting. And then in the third trimester, another very interesting immunologic phenomenon occurs. Basically, the third trimester is a more inflammatory trimester, and that's because the body is getting ready to deliver the baby. So basically, the mature fetus and the mature placenta will start releasing certain molecules that are recognized by the immune system. So basically, these molecules will bind to receptors called toll-like receptors on immune cells and encourage those immune cells to start producing pro-inflammatory cytokines. And those cytokines are very important because they enhance the expression of contractile proteins in the uterus. So again, the third trimester is more of an inflammatory trimester, if you will. So we think that women that catch COVID in the third trimester are more susceptible to adverse outcomes because they are more inflammatory. So they have more of a propensity to develop that sort of cytokine storm that we saw in the last slide. And then the other thing that you have to remember as internists is that immunologic changes are not the only changes that are occurring in a woman's body that can increase her risk of morbidity from a respiratory infection. There are also physiologic changes that occur. So for example, there's, during pregnancy, a relative endothelial dysfunction to enable decreased vascular resistance to accommodate a pregnancy. A woman who is pregnant will already have a hypercoagulable state, and we know that COVID is a hypercoagulable virus. And we also have a restrictive lung pathology during pregnancy, which is caused by the gravid uterus. So a woman who's in her second and third trimester of pregnancy will have a reduced lung volume, so will have decreased respiratory reserve, and she won't be able to clear secretions as well, and she'll probably have a difficult airway. So this really increases the respiratory morbidity that occurs with COVID. So how can we protect, these pregnant women from developing severe cases of COVID? And the obvious answer here is vaccination. But unfortunately, there's a lot of bad press surrounding COVID vaccination. While the message is usually consistent among most university-based practitioners, there's still GPs, obstetrician, midwives, obstetric nurses in the community that are recommending against vaccinating women for COVID, despite national and international obstetric guidelines recommending it. And this it's very difficult to come back from that, because as healthcare professionals, we have to go against some of our colleagues and actually recommend vaccination. And then there's this whole issue of false news surrounding the COVID vaccine. So there's some false news that have made the mainstream media, claiming that the COVID vaccine increases the chances of miscarriage, increases the chances of infertility, increases the chances of developing ovarian cancer, of developing specific autoimmunity against the ovaries. All of these claims have been scientifically debunked. But the damage that these claims have made in the general population is, very difficult to overcome. And then you have certain religious groups who are actually saying that the COVID vaccine contains substrates used from aborted fetuses, which makes absolutely no sense, but it's still something that's being put into the mainstream media that really enhances public distrust about vaccinating and pregnancy. And even if, the Pope recently came out to say, well, vaccines are perfectly ethical, they don't contain any fetal parts, and everybody should be vaccinated if he or she or they want, the fact that phase 3 vaccine trials excluded pregnant women only enhances the public distrust that people have in vaccines during pregnancy. So how can we combat all of these misconceptions and these fake newses, if you will? And the answer is by doing actual studies and producing real data. Just keep a watch in the literature, because vaccine studies in pregnant women are coming out more and more. And there's been over several hundreds of thousands of pregnant women that have already been vaccinated across the globe. So I'm only going to present 2 studies showing the relative innocuity of the vaccine, but please do watch the literature, because more and more studies will be popping up within the next few months. So the first article that I wanted to present is basically a study that comes out of Israel, where the vaccine rollout was probably the most efficient in the world. And basically, they were able to look at over 30,000 cases of 30,000 cases from the Maccabi Health Fund. And the Maccabi Health Fund is basically an insurance company that covers 25% of Israel's population. And they included all members who became pregnant between December 2020 and February 2021. And newly vaccinated women were matched 1-to-1 with unvaccinated pregnant women by age, gestational age, and geographic area. And patients were excluded if they had received their vaccines preconceptually or if they had had a prior COVID infection. And the primary outcome was COVID-19 infection 28 days or more after the second vaccine dose. And they were also able to follow certain pregnancy and birth outcomes in this study, which is very cool. So all in all, they were able to include 7,530 pregnant women who were vaccinated during pregnancy, and they were able to compare those with 7,530 unvaccinated women who had never caught COVID before. And the outcomes I'll present in the next slide. So again, this matched cohort, so vaccinated versus unvaccinated, were well matched for patient age, ethnic background, and multiple other clinical attributes, including receiving influenza and pertussis vaccination during pregnancy and chronic medical conditions. So again, this is a very comparable vaccinated versus unvaccinated group. And what they were able to demonstrate very well is that overall, in the mean 37 days of follow-up, unvaccinated pregnant women tested positive to COVID twice as often as the vaccinated pregnant women. So obviously, being vaccinated protects you against catching COVID. And what they were able to demonstrate is that if you were unvaccinated, you also had a higher risk of being hospitalized. But the rest of the maternal and fetal outcomes were pretty similar between both groups. So looking at the abortion rate, it was very similar between both groups. The abortion rate was 1.7 in the vaccinated group versus 1.6 in the unvaccinated group. This is very low, but you have to keep in mind that, I'll backtrack. In a normal pregnant woman, every single time she becomes pregnant, you have around 10 to 30% chance of miscarriage, depending upon maternal age. So an abortion rate of 1.7 is very low, but these patients were already pregnant when they were included in the study. So we're not talking about first trimester miscarriages here. And then in terms of all of the other outcomes that they were looking at, so intrauterine growth restriction, preeclampsia, stillbirth, maternal death, pulmonary embolism, whether or not these women delivered at term, and the infant weight, both of those are very comparable amongst both the vaccinated and the unvaccinated group. And then interestingly enough, either vaccinated or unvaccinated, if you tested positive to COVID, both groups had similar types of symptoms. So the vaccination doesn't prevent you from having symptoms if you do get infected with COVID. So, from this study, it's pretty clear the vaccination decreases your chances of catching COVID and your chances of getting hospitalized. But what about vaccine safety? Oops, sorry. So vaccine safety was addressed by this recent publication that appeared on June 17th in the New England Journal of Medicine. And basically, this is a population-wide cohort study where data was obtained by several ways. So first off, there's something called a vSafe, which is a smartphone-based active surveillance system that was developed specifically for the COVID-19 vaccine. And basically, this prompts the vaccine recipient by text to report any side effects at several time points 12 weeks after the final COVID vaccine. And this vSafe surveillance system or vSafe app also asks the patients if they're pregnant. And if the patient responds that they are pregnant, the patient is contacted by phone and enrolled into the vSafe pregnancy registry after consent. And they also use data from the National Spontaneous Vaccine Adverse Event Reporting System, which is a system that's administered by the CDC and the FDA. So healthcare providers have to report certain adverse events after vaccination, and this includes pregnancy-related complications that require hospitalization and congenital anomalies. And patients can also report any adverse events they think is due to the vaccine. So they used the vSafe surveillance. So this, we're talking about the app. They used the vSafe surveillance to see the proportion of side effects or the types of side effects that patients had. So briefly, between December 2020 and February 2021, which coincided with the first 3 months of the vaccine rollout in the States, they were able to identify 35,691 patients that were pregnant, and they were matched, or sorry, they these patients received 50% Pfizer vaccine, 50% Moderna vaccine. Both groups are relatively comparable in terms of maternal attributes. And these patients that received the vaccine during pregnancy were also matched by age with non-pregnant vaccinated women as a comparator. So again, they use this vSafe surveillance app to demonstrate that the side effect profile was similar to that of the general population. So after the first dose of Pfizer, patients namely reported pain, fatigue, headache, myalgia, chills, and fever. This percentage went up after the second dose. And the pregnant women were here in the dark blue. The non-pregnant women are here in the light blue. And you can see that the side effect profile is similar for both first dose and second dose with Pfizer and first dose and second dose with Moderna. So it does not seem that a pregnant woman will have more side effects than her non-pregnant counterpart after receiving the vaccine. Then they used the vSafe registry to look at maternal outcomes. So from the vSafe registry, they were able to enroll almost 4,000 patients, 94% of which identified as healthcare personnel, and half of those patients received Pfizer, the other half received Moderna. Again, maternal attributes are relatively comparable between those that received Pfizer and those that received Moderna. And during the study period, 827 women were able to complete a pregnancy. And it's on those women that they were able to look at certain pregnancy outcomes and neonatal outcomes. So from that entire cohort, there was 12.6% of patients that had a spontaneous abortion. Now, again, 12.6% is actually very comparable to published incidence, and it's usually what we'd expect in the general population. Again, the miscarriage rate is related to maternal age and varies between 10 and 30%. In terms of stillbirths, the incidence that they had in the cohort that was able to complete a pregnancy is comparable to published incidence, as were the rest of the outcomes that they looked at. So preterm birth, small for gestational age babies, congenital anomalies, and neonatal deaths were all very similar to what is usually published in the literature. So, from this publication, there's a lot of evidence to support the fact that the vaccine is not increasing pregnancy-related complications and is not causing any issues with the babies. Now, if just demonstrating that the COVID vaccine does not seem to adversely impact maternal or neonatal outcomes, if just this is not enough to convince your patients to get the vaccine, are there any other advantages of vaccinating? So the arguments that I use are passive immunity. So just to backtrack a little bit, when a baby is born, that baby has a very immature immune system, and they're very susceptible of becoming sick if they catch bacteria and viruses. And nature's way of remedying this situation is by providing something called passive immunity, where the mother basically shares her immune system with the baby. So I'll explain. During pregnancy, the placenta is able to transfer maternal antibody into the fetal circulation. So on the maternal side of the placenta, there's something called the FcRn receptor. And the FcRn receptor will bind with very, very high affinity maternal antibody and will flip the maternal antibody directly into the fetal circulation. And one thing that you have to know about this process is that it's very efficient. So if you look at one particular antibody, so a specific antibody against flu, for example, the concentration that you're going to find in the fetal circulation is actually higher than what you find in the maternal circulation. Now, the other thing that you have to realize about this process is that the FcRn receptor recognizes the constant portion of the antibody and recognizes certain sugar molecules that are on the constant portion of this antibody to really increase the binding strength so that it can transport maternal antibody efficiently into the fetal circulation. So I'll come back to passive immunity on the right side. But just to give you an idea, again, infants and neonates have a higher risk of severe and critical COVID, as we saw in one of the first slides. And again, neonates rely heavily on vertical transmission for passive humoral protection. So again, they rely on the maternal humoral protection during that dangerous 6-month post-birth or vulnerable period. And the transplacental IgG transfer starts in the first trimester, but it increases exponentially in the second and the third trimester. So if you have a baby, for example, that's a preterm, this baby might not be adequately protected just because it has not benefited from a long enough exposure to this transplacental maternal antibody transfer. And then the other thing that I'll touch upon a little bit later is, the protection that's conferred by breast milk. So we do have antibodies which are a little bit different. They're called IgA antibodies. They're actually transmitted through breast milk. So these antibodies will go protect mucosal surfaces in the baby. And these antibodies are very good at blocking viral entry or bacterial entry into cells. So again, these antibodies protect the mucosal surface of the baby, which comes in really handy when you have a virus that infects the respiratory mucosa. So there was an article that was recently published, I think this was back in August, and they demonstrate that there is efficient maternal to neonatal transfer of antibodies against COVID, both from natural infection and when you get vaccinated. So basically, in this study, it's an Israeli study. Again, the Israelis are a lot more advanced in terms of vaccine rollout than we are. They were able to recruit 232 dyads. So a dyad is a sample coming from mom and from umbilical cord at time of delivery. And they recruited those patients over a 1-year period, so from April 2020 until March 2021. And they separated these women or these dyads into 3 groups. So the control group right here, where we had 66 dyads, these are patients that have never been vaccinated and have never had any prior COVID infection. The second group is the past COVID infection group, where we had 74 dyads. So these are patients that have had COVID in the past during the pregnancy. And then the vaccinated group, where there were 92 dyads, these are patients that were vaccinated during pregnancy. And again, just as a reminder, sample dyads are both maternal blood and cord blood obtained at delivery. And they basically assayed antibody titers to the major COVID antigens. So antibody titers to the spike protein 1, spike protein 2, the receptor binding domain, and the nucleocapsid antigen in both the maternal blood and the cord blood sample. So this is from natural infection. So they are able to demonstrate that first and second trimester COVID infection is associated with robust transplacental anti-COVID antibody transfer, but not third trimester infection. So I'll show you in this diagram right here. So the way that they calculate the efficiency of transplacental antibody transfer is by something called the transfer ratio. So the transfer ratio is basically a ratio of how much antibody do we have in maternal circulation versus in the fetal circulation. So how much of that antibody is in the maternal blood versus the cord blood sample. And a transfer ratio of 1 or more, more than 1, implicates that the transfer is done preferentially towards the baby. So the baby, the cord blood sample has more specific antibody in it than the maternal blood sample. And we see that this, the baby has a higher concentration of antibodies to the spike 1 protein, spike 2 protein, receptor binding domain, and nucleocapsid in the first and second trimester infections, but not in the third trimester infection. So in the third trimester, you have preferential retention of these antibodies in the maternal circulation with a transfer ratio of less than 1. So we'll come back to that in the next article that I'm going to present. In terms of vaccination, they were able to demonstrate quite nicely that the baby seems to be as adequately protected as the mother. And if you look at panel A, this is what happens during natural infection. So at around 15 days post being PCR positive, you develop higher titer of antibodies to spike 1 protein, spike 2 protein, receptor binding protein, and nucleocapsid. And you'd see the same thing when you vaccinate mom. So around 10 days after the first dose, mom is producing appropriate levels of spike 1, spike 2, anti-spike 1, spike 2 antibodies, as well as anti-receptor binding domain antibodies. She's not producing any nucleocapsid antibodies because that's just not included in the vaccine. So that's to be expected. And you can see that what occurs in a baby is exactly what's reflected in mother. So we're able to, within 10 days of receiving the first dose, we're able to measure antibodies against these major proteins in the fetal circulation. And you can see this very well in these graphs as well. So if we're just looking at the spike 1 protein, before vaccination, mom and baby don't have protective titers. And then right after the first dose, you see that the antibody titers increase. They increase further after the second dose. Now, both maternal and fetal antibody titers are similar. And these antibody titers are maintained several weeks after the mom is fully vaccinated. And again, we see the same thing for the spike 2 antibody and the receptor binding domain antibody, but not for the nucleocapsid antibody, just because that is not contained in the vaccine. And we don't see that for IgM either, because IgM does not get transferred across the placenta. Now, I just wanted to come back to this third trimester natural infection. So they are able to show in this paper that third trimester infection was associated with a reduced transplacental transfer of the anti-COVID antibodies. And, that's very interesting finding, because it's an argument that we can tell our patients that if they catch COVID during at least the last part of pregnancy, their babies might not be adequately protected against COVID postnatally. So there's a Cell article that was recently published that looked into this. And unfortunately, I don't have the time to go into the details, but if you have questions about this study, I can show you some additional slides during the question period. But they found that compared to other antibodies, so for example, flu and pertussis, for which moms get vaccinated during pregnancy routinely, the anti-COVID antibodies from a third trimester natural infection exhibit abnormal glycosylation patterns. So those are the sugar molecules that are stuck to the antibody that permit the FC receptor to recognize it and to bring it into the fetal circulation. And this abnormal glycosylation pattern alters their ability to be actively transported across the placenta. And they also looked at the function of those antibodies once they got into fetal circulation and saw that they don't function as well as they do in the maternal circulation. So the authors concluded that the glycosylation pattern seen in acute third trimester COVID infection was likely due to inflammation and was likely to represent a maternal advantage to the detriment of the fetus. And this was not seen in first or second trimester infections, likely because the inflammatory stimulus was removed and the glycosylation patterns normalized to permit efficient transplacental transfer. Now, in terms of passive immunity, there's not very much, in terms of the other type of passive immunity that we're talking about, there's not much literature that suggests that IgA is being transmitted into breast milk. There are a few articles that are making their way into the literature. They're showing that 30 to 50% of samples taken from the breast milk of women that were vaccinated during pregnancy do contain anti-COVID antibodies that are IgA. So probably that those antibodies do serve a protective purpose as well. I'm not going into these two studies because they're not done very well, but again, they do introduce the concept that we do have some passive protection as a result of COVID vaccination during pregnancy. Now, I only have another few slides, and I'll be finished in about 2 to 3 minutes. Some of you might encounter patients that say, well, I have allergies and therefore I cannot be vaccinated. This is not a very good argument either, and you can easily debunk that with this slide. So basically our our Quebec Allergy and Asthma Immunology Association has come out with this slide. And basically all patients that either have food allergies, insect venom allergies, medication allergies, respiratory allergies, chronic urticaria, contact dermatitis, or an allergic reaction occurring more than 1 hour after the administration of a past vaccine, including the COVID-19 vaccine, most of these patients can be vaccinated. Actually, all of these patients can be vaccinated according to regular precautions. So vaccinated in clinic with a 15-minute observation period. Now, in patients that have a history of immediate allergic reactions, so this is within 1 hour after the administration of another vaccine that contained polysorbate, and that includes the flu vaccine, for example. These patients can receive the COVID vaccine, but just with an extended observation period. So they don't have to be tested. They don't have to be seen by an allergist. They just need an extended observation period. Now, the patients that had an immediate reaction to the COVID vaccine, so less than 1 hour after getting the COVID-19 vaccine, or a severe allergic reaction occurring within 24 hours after the first dose of the COVID vaccine, these patients have to be reported to public health for an initial evaluation. And if public health deems that the reaction was mild, they will recommend that the patient undergoes regular vaccination, but with an extended observation time. And if they deem that the patient might have had anaphylaxis, they're going to refer that patient to an allergist for evaluation. And then it says here that patients with a previous allergic history to polyethylene glycol should be referred to an allergist. That's still true, but really, almost 99% of patients with a previous history of an allergic reaction to polyethylene glycol can be vaccinated normally. So, for most of your allergic patients, just having an allergy is not a contraindication for receiving the vaccine. And if all of the arguments that I just presented within the last 45 minutes are insufficient to sway your vaccine hesitant or your anti-vax mom from getting vaccinated, all you have to do is, just post stuff on your social media. So try and dilute all of that fake news and try to replace it with something true coming from credible sources. So I think that, as internists and as physicians, especially operating in a tertiary quaternary center, we have a professional responsibility to educate our patients, but also educate our colleagues about the importance of vaccinating pregnant women. And it's very important that if ever you see a woman of reproductive age or who is pregnant in your clinic, even if you're not seeing her for her pregnancy, take the extra 5 minutes to ask if she's vaccinated and explore why she isn't vaccinated, because you might actually end up saving a life. That's all I had for today. I guess I will stop sharing my screen.
Thank you so much, Dr. Genest. Thank you for that outstanding presentation, a wonderful overview of what to do with our patients like this. And as you mentioned, it's very controversial, not controversial, but patients are coming to us with many questions. So thank you so much. We are open for questions. I see a few questions in the chat. Something about people traveling. Is there still disagreement on this among major countries about getting vaccine, or is it pretty standard that everyone agrees pregnant women should get vaccinated?
Pretty much everyone agrees that women should get vaccinated. So the European Society of OBGYN, the US, the Canadian guidelines from OBGYN have recently come up with guidelines saying that all women who don't fit within those exclusion criteria should be vaccinated.
Fantastic. Question about fertility issues with the vaccine. You mentioned that, so there's really no evidence, if I understand correctly from your presentation, right? So to answer that question, is there data that says that there is no fertility issues, or is there no data that says there is?
So, okay. All the data is trickling in. For what we can see from cohort studies, we're not seeing an increased incidence of miscarriages. However, they haven't looked at the time to pregnancy. So, it's very difficult to assess the fertility post-COVID vaccination in studies such as these. But what I can tell you is that a lot of people are getting vaccinated right now. And my husband's a neonatologist and he works a lot in databases. And what they're seeing is a huge spike in births right now. So obviously the COVID vaccine has not put a dent in our ability to reproduce. So, there's nothing pointing towards an increased chance of infertility with the COVID vaccine.
Many anti-vaccination people invoke the idea of ADE causing shortened lifespan. Any comments on that?
Of what?
ADE, Arnold Zadulka is asking that question.
Of ADE? What's ADE?
I don't know what ADE is. Maybe Dr. Zadulka could come back to us and tell us more what ADE is. There's a question about vaccination in, sorry, I think he may have come back to us. No. A question about vaccination in the conception period. That there might be issues at that time with biodistribution, pharmacokinetic data, because they can locally stagnant. The effect of the vaccine may be diminished. Do you have any comments about the peri-conceptual period?
If you have an opportunity to vaccinate your patient, just do it. I don't really understand the sense of the question. Is it bioavailability of the vaccine, or
that there is potentially catatonic limit particles and spike proteins that are immunogenic and cytotoxic?
I mean, there could be, but that's just like any other vaccine, and or any other viral infection. There is a potential for it, I guess. But does it really affect fertility? Does it really affect maternal outcomes? Does it really affect fetal outcomes? Probably not. I think you're a much higher risk of, say, for example, there was a potential increased risk of infertility with the vaccine. And I'm not saying there is, I'm just putting it out there. Say that was the case, your chances of being infertile post getting COVID, for example, would be much higher, correct? So I don't think that it's an appropriate argument to say, well, getting the vaccine, we alter biodistribution, or I don't think it's an appropriate argument given the situation which we are in right now.
Fantastic. ADE was adverse drug effect. So total sense, of course. Many anti-vaccination people invoke the idea of adverse drug event causing shortened lifespans. Any comments on that? Is there any animal experimentation, any animal data that would suggest or dispute this?
That I have absolutely no idea, but at the same time, COVID will definitely shorten your lifespan, and it will definitely shorten the lifespan of your baby if you do die during pregnancy. So I don't think that, with the scientific data that we have right now, we're able to answer that question. Maybe, heaven forbid, in 100 years, someone will discover that COVID does decrease vaccine or lifespan. But again, I don't think that that is an appropriate argument to stop vaccinating patients that would definitely benefit from it.
In your opinion, what is the best counter-argument for those who refuse to be vaccinated because the vaccine is too new? I think that's a very important question, actually, because it comes up, we get that for, not just pregnant women, but everyone. What is your argument against that?
So usually what I'll tell patients is that you really have to weigh the risks and the benefits, because, if COVID were Ebola, for example, and only occurring in, certain areas and not this widespread pandemic that specifically targets old people, pregnant people, then there's not really an argument to be vaccinating widespread. But, if the chances of you becoming sick or of you dying from COVID outweigh your chances of getting sick from the vaccine, then that's definitely an argument that you have to keep in mind. And that's a sound argument. Because, if your chances of potentially having a vaccine adverse drug event are X and your chances of dying from COVID are, 10% when you're pregnant, then I think you have to take the least of the worries. Does that make sense? So it's really just weighing the risks and the benefits within a particular situation.
Are maternal and fetal outcomes different depending on the variants of concern?
The COVID variants, you mean?
Yeah.
My guess, absolutely. I think it's no coincidence that we're seeing an increase amount of pregnant women that are in intensive care units and in the COVID ward. And I think that really does coincide with the Delta. I haven't really looked into the literature in terms of, which variants are associated with which complications, but I just, clinical acumen, I think that the Delta variant is a little worse than what we were seeing in the first and second waves. I don't know if maybe someone from OB Med has any comments on that.
Hi, this is Isabel. Thank you so much for this wonderful overview and detailed approach to how to tackle vaccine hesitancy among ourselves and our patients. So really, thank you. Regarding the Delta variant and the Alpha variants, we do have cohorts from the UK that have compared the risk of severe morbidity in pregnancy, compared Alpha to wild type and Delta to Alpha. And so far, Alpha seems to be associated with a 1.5 increased risk of severe morbidity compared to wild type, and Delta has the same 1.5 increased risk of severe morbidity, but as compared to Alpha. So they are associated with worse outcomes, but we just don't know how much more than the non-pregnant population. But within pregnancy, they seem to be worse.
Thank you, Isabel. That's very helpful. Thank you so much. We have one last question here. How long does passive transfer of immunity last in the newborn?
So the lifespan of an antibody molecule is anywhere from 3 to 6 months. So you can say that the baby is probably protected for 6 months postnatally, but that's for for a term baby. So if you have a preterm baby that was only able to get the second trimester and maybe early third trimester transplacental transfer, the protection probably doesn't last as long because the titer of antibodies that you're going to have in fetal circulation is not as much as a term baby. So again, it really depends on when your baby's born, but for a term baby, it's usually around 6 months postnatally.
One last question, just because I'm seeing there's a lot of chat about this. People are asking about corn protein. Is corn allergy an issue towards vaccination?
None whatsoever. No.
None whatsoever. We don't worry about corn protein for our corn allergies in our patients. Geneviève, thank you. That was terrific. We have many comments here congratulating you on your terrific presentation. They're all coming in the comments, and many thank yous. So, on behalf of the Department of Medicine, thank you so much for this outstanding presentation. And that was very informative, very educational, and super well done. So thank you. Thanks everyone for attending, and don't forget to answer the survey that's going to come to you in a few minutes. Bye, have a great afternoon.